Good morning. This is a review of the endocrine system. And please excuse my lovely headset, but my microphone wasn't working, so I had to figure this out. All right. So the endocrine system, it's made up of organs and glands that secrete hormones and release them into your circulation. You can have hyposecretion or hypersecretion. Your body wants to stay in homeostasis, which means keep everything at an even level, but sometimes that doesn't work and too little hormone is released or too much. So these hormones, what are they responsible for? What do they do? They help maintain vital functions. It helps, it's your growth and development, response to stress and injury, energy metabolism, reproduction, and your fluid electrolyte balance. Some things that can affect your endocrine system are age, your diet, could be hereditary, trauma, if you get hit in the head or have some sort of brain injury that could affect your hormones. Could be environmental factors, or it could be from a tumor or even surgery. So your endocrine glands, you have pituitary gland, which you have an anterior and posterior. The anterior is the front part of the pituitary gland. The hormones that are stored in the anterior portion is your adrenocorticotropic hormone, which stimulates the adrenal cortex, follicle stimulating hormone, luteinizing hormone, which those stimulate the ovaries, growth hormone, which stimulates bone. You have prolactin, you have thyroid stimulating hormone that stimulates the thyroid. You have a posterior pituitary, that's the back portion of the pituitary. That has vasopressin, which is also known as the antidiuretic hormone, and then oxytocin, which stimulates the muscles of the uterus. Your hypothalamus gland activates and controls the autonomic nervous system, which is basically your rest and digest system. And it also processes many somatic functions, such as your body temperature, sleep, appetite. Thyroid controls your body metabolism, and the hormones that's the thyroid stimulating hormone stimulates the thyroid hormones, which are thyroxine, which is T4, triiodothyronine, T3, and then there's also thyrocalcitonin. Parathyroid hormone controls calcium and phosphorus metabolism. Your pancreas, yes, your pancreas is an endocrine organ. It influences your carbohydrate metabolism, your fat and protein metabolism. It also produces insulin and glucagon. Your adrenal, for your adrenal glands, which they're like little hats sitting on top of your kidneys. Your adrenal glands, part of your sympathetic nervous system. It produces epinephrine, also known as adrenaline, and norepinephrine. This is what produces your fight or flight response. And then, of course, your ovary and testes are the ones that control the development of the sex characteristics. Ovaries produce estrogen and progesterone, and testes produce testosterone. Here's where all of your different glands are located. You can see up in the brain, you've got your hypothalamus and your pituitary gland. You've got your thyroid gland and parathyroid glands are in your neck. Pancreas, you've got your adrenal glands, there they are sitting on top of your kidneys. And then, of course, ovary or testes. Your pituitary gland is considered your master gland. It's located at the base of your brain, just below the hypothalamus. Its primary function is to store and release hormones. It promotes the growth of bone, body tissue influences water absorption by the kidney. All right, so if you have your pituitary, you have hypopituitary issue. That means that there is a problem with not enough hormone being secreted. It can be caused by a tumor or trauma. It could be autoimmune. It could be a stroke. Hormones that are usually affected are the growth hormone, LH, FSH. Sometimes it affects TSH. Typically, you'll see this affect growth hormone. Some signs and symptoms would be obesity, infertility, fatigue, low blood pressure, headaches. If it's affecting your growth hormone, that's when with children, they always use the growth chart. And if your child is not growing as they should, they're not as tall as they should be, this is one of the things they'll check, is they'll check the growth hormone. And when they are suspicious of a hyposecretion, you want to test it by doing a stimulation test, which would introducing that hormone in and check, and you would want to draw the blood, see what the hormone levels are, and then do a stimulation test. So if failure of the hormone to actually increases with the stimulation, that does show hypofunction. You have a hyperpituitary, that's too much. Typically, this is caused by a pituitary tumor. Hormone most often affected is growth hormone. That's why up there it says acromegaly, because that is growth hormone causes the body to continue to grow bone. Usually you'll see large hands and feet, a thickening and protrusion of the jaw, they'll have visual disturbances, a deepening of the voice, thickening of the tongue, narrowing of the airway. So this would be, you would do suppression tests, whereas if it's hypo, they would do a stimulation. Hyper, you would do a suppression. So interventions, they would give medications to suppress the hormone. They may need to do radiation of the gland to basically reduce the size. They may have to completely remove the gland, and that's called a hypophysectomy. Here's an example of what acromegaly would look like. You can see that this woman was a very normal looking child, and even young adult. You see as she gets older, her nose is continuing to get larger, her jawbone is getting larger. Then the last one, you can see how large her hands are, and her face, and that's just too much growth hormone. So they want to go in, let's say we wanted to go in and do a transvoidectomy, or transvoidal surgery, hypophysectomy. Whoa, Lordy. Sorry, I just, for some reason, just can't talk today. This surgery is done, the most common way is up through the nostrils, up through the nose. They also can do it in your mouth, like at the base of your gums. But this is the most common way, is through the nose. One thing you have to watch for after this surgery, of course, we always watch for infection. You'd want to keep the head of the bed elevated, but you want to see if they're complaining about, they feel like they're just having a runny nose and constantly having fluid coming out of their nose. You need to get that fluid and put it on paper and look at it, because if a halo forms around it, that will tell you that it's actually cerebral spinal fluid, and that is a complication that with a leak from the cerebral spinal fluid leaking out. Excuse me. The halo around it is actually glucose. You want to also monitor for diabetes insipidus, and after they've had their pituitary removed, hypopituitarism, because now that they've had it removed, they're going to need hormone therapy, since their body will no longer have that hormone. So hypothyroidism, this is not enough thyroid hormone. You can have primary or secondary. Primary would be a problem actually with the thyroid gland, or you could have secondary, which means that the thyroid's not being stimulated by the pituitary gland. Signs and symptoms of hypothyroidism: fatigue, intolerance to cold, weight gain, dry skin, bradycardia, constipation, puffiness and edema around the eyes and face, forgetfulness. They walk around in a constant state of brain fog. They may or may not have a goiter. That would be an enlarged thyroid. Blood tests are typically drawn. You would draw some blood and check the thyroid levels. Now, for a hypothyroidism, you would probably see that the T3, T4 hormones are low, but TSH is elevated. So that can be confusing to some people, thinking, well, why is the TSH elevated if they're hypothyroidism? Well, it's because that TSH is a stimulating hormone. So if it's stimulating and the hormone is not being released, then that stimulating hormone is going to keep giving out more and more and more, trying to make the hormone be released. So that's why it's going to be elevated. So with this, they're going to have lifelong thyroid hormone replacement therapy, typically levothyroxine or Synthroid, I think is a brand name. Hyperthyroidism, exact opposite. It's hypersecretion of the thyroid hormone. Typical, one of the most common causes is Graves' disease. Everything now is fast. Now you got your fast metabolism, you're nervous, you're intolerant to heat, you have weight loss, your heart's going to race, and you have palpitations, you have diarrhea, you have protruding eyeballs and a goiter. Again, blood work to test your levels. Now this time your T3 and T4 are going to be elevated and your TSH is going to be low because it's not going to need to be stimulating because there's already plenty out there. So what they'll do is give you some antithyroid medications, or that may not work. So then they may want to give some iodine preparations, or they may want to do radioactive therapy to destroy part of the thyroid. If none of that works, then they would actually do a thyroidectomy and remove that thyroid. Now they remove that thyroid. Now you've gone from hyperthyroid to now hypo, because then you're going to have to take hormone replacement. This lady, it's exophthalmos. That's the term for the eyes popping out like that. There's a goiter. She's got a huge goiter, and that's kind of an interesting picture because you can literally see the outline of that thyroid and you can see how huge it is. Thyroidectomy, we just talked about that, removal of the thyroid gland. They would prefer only take out a portion of it, but if they have to take out the entire gland, they will. With post-op, you need to watch them for respiratory distress. Now, they're going to have surgery here on their neck, and if there's a lot of swelling, that could cut off their air supply. So that's why you need to be prepared in case their air supply is compromised. Limit your patient from talking, avoid neck flexion, and monitor for thyroid storm. So what's a thyroid storm? I will tell you. So this is a life-threatening condition when you have uncontrollable hyperthyroidism. Now, if you've gone in and done surgery and removed their thyroid, excuse me, or even a portion of it, that could cause your thyroid just to dump a lot of hormone into your thyroid hormone into your body. So now you've got this huge amount of thyroid hormone. This can cause elevated temperature, tachycardia, hypertension, agitation, restlessness. It can cause death. So a lot of times they will do preventative measures, like give antithyroid medications prior to surgery. They may want to slow the heart rate with some certain medications and sedatives. Prevention is always the best choice rather than trying to treat a problem after it occurs. Myxedema coma is the exact opposite. That's severe low thyroid production. That's everything: hypotension, bradycardia, hypoglycemic respiratory failure and coma. This also could be death, could lead to death. So this would be where the interventions would be to give levothyroxine IV intravenously, and then of course monitor and replace anything like if they need corticosteroids. So basically monitoring the patient closely. Here's a picture of, it says myxedema coma on there, but it does show this is mostly the periorbital edema. So that's all that edema right around the eyes, periorbital. Thyroiditis, inflammation of the thyroid. A lot of times it's caused by an autoimmune disorder like Hashimoto's. They will have a painless enlargement of the thyroid gland and have symptoms of hyperthyroidism. So the diagnosis would be to check thyroid levels and possibly even a needle biopsy. Needle biopsy because they would be looking to see if maybe it's cancer. Anytime something starts enlarging, have an ultrasound, look at the thyroid, look for any nodules. Often, a lot of people have benign nodules on their thyroid, but they would definitely want to follow up to see if it is cancer. Now, thyroid cancer, you would have symptoms pretty early because you would have nodules, you would have problems breathing and swallowing. So the physician would check the thyroid pretty quick, and if cancer is or anything suspicious, they could do a needle biopsy. If it comes back as cancer, they'll go in and just remove the thyroid. So that's typically, if you're going to have cancer, that's one of the best ones to have because it's usually caught pretty quick. If they can't, for some reason, somebody cannot have surgery and cannot have their thyroid removed, then basically they would be given medication to control the tumor growth. They wouldn't cure it, they would just control the growth. All right, moving on to adrenal insufficiency. This is called Addison's disease. This is when you do not have enough of your adrenal hormone. It would be ACTH, you would have aldosterone, cortisol. Primary insufficiency is if there's an autoimmune disease or infection of the actual adrenal cortex. A secondary insufficiency would be when the pituitary gland doesn't secrete ACTH because the gland is under functioning or has been surgically removed. Or abrupt withdrawal of steroid therapy. This is why when people take steroids, like prednisone for a sinus infection, they have to taper off. They can't just take the medication and then just stop cold turkey, because if they do, that can cause the adrenal gland to not secrete the ACTH. So steroids must be tapered off to prevent this. So adrenal insufficiency is Addison's disease. Exact opposite is Cushing's. Cushing's is excessive secretion of the ACTH. This is often caused by a tumor of the adrenal cortex. Signs and symptoms: the person would have a buffalo hump and a moon face, enlarged abdomen with thin extremities. So their arms and legs can be very skinny, and then they'll just have the whole trunkal obesity. It'll be very large in the of their trunk. Easily bruised, hypertension, weakness. Basically, to diagnose it, they would do like a 24-hour urine test. And again, there's also a suppression test that can be done. Treatment could be surgery on the pituitary gland, could have to give them medication, adrenalectomy, which means they would take out that adrenal gland, but then now, of course, you have to have replacement therapy, hormone replacement therapy. Here's a picture of the differences between Addison's and Cushing's. And you can look and see the differences here. Cushing's, I always think of that person has a cushion. They're larger. They have too much hormone, too much cushion. That's Cushing's. All right, diabetes insipidus. People think diabetes and immediately go with thinking insulin, and this is not. This has nothing to do with insulin. This is actually a disorder of the salt and water metabolism. It got its name because people are very thirsty, and then they drink a lot and they pee a lot. So it's like, oh, okay, well that's diabetes, but that's how it's got its name. But it has nothing to do with the diabetes that we're most familiar with. This is often from brain tumors, or it could be neurosurgery. Any kind of surgery in there in the brain could cause DI. Also, it can be caused by drug therapy like lithium. Lithium is a psych medication that is very similar to salt. Some people do say it's salt, but it's just very similar to salt. So that can cause you to have diabetes insipidus. Also, it can be caused by excessive water intake. This sometimes is schizophrenia. Schizophrenia can cause an uncontrollable urge to drink. It's called psychogenic polydipsia. So they're going to be heavy urination, so they're going to have high sodium. They're peeing out all the water, so they're going to have real high sodium levels. This is a problem with vasopressin, which is an antidiuretic hormone that's produced by the hypothalamus and stored in the pituitary. So I thought I had it. Let me see. Oh, here it is. Okay. Okay. So diagnosing it, they would look at the urine and plasma osmolality and urine specific gravity and water deprivation test. So some of the interventions, they'd want to replace your fluid and electrolytes, hormone therapy given the synthetic vasopressin, a low salt diet, strict intake and output. They're often, the synthetic vasopressin is DDAVP. All right, here's the opposite of diabetes insipidus. This one is syndrome of inappropriate antidiuretic hormone. Now we've got too much ADH, whereas before we're having to replace it with vasopressin. Now this time we have too much. So now they're going to retain fluid. So they're going to have too much fluid, and then they're going to have low sodium. Low sodium, that's typical signs of that is confusion, seizures, loss of consciousness, could have muscle cramps. Again, diagnosed by urine and serum osmolality tests. Want to correct the underlying cause, figure out what's causing it. If it was some sort of neurosurgery, or if there's a tumor, you basically want to determine what's causing it and correct it. You know, we treat symptoms, we can treat symptoms, but it's a whole lot better to treat what is causing the problem. This one, because they have so much fluid, their fluids are restricted. They are often given medication that will help with hyponatremia, tolvaptan or Samska. It blocks the action of ADH. So they've got too much ADH, so it blocks that, so that the symptoms get better. So you would have to watch the sodium levels very closely. Anytime you do like any kind of replacement of any kind of hormone, or anything, sodium, potassium, you don't want to do it fast. You know, you always think, oh, let's just dump it in there. And you want to do it very gradual, because it's be too much for your body. You could end up having seizures. You want to just do very gradual changes. All right, now we're up to diabetes mellitus. This is the diabetes that we know and love. You have three different kinds. You've got type 1, type 2, and gestational. Type 1 is what used to be called juvenile diabetes. It's usually diagnosed when people are children. This one is an actual problem or a malfunction of the beta cells in the pancreas. The pancreas just doesn't make insulin. So they have to go on insulin therapy because their body does not make it. Type 2 diabetes is what used to be called adult onset. It might still be called adult onset, but I haven't heard that in a while. But that's more so you've got insulin, your body just can't use it properly. It doesn't, it's not able to push it into the cells. So it's an insulin resistance. It's an insulin intolerance. So people may or may not need to take any insulin because they have insulin. One of the causes is being overweight, but don't feel like skinny people can't have type 2 diabetes, because they can. Gestational diabetes occurs as a result of the stress of pregnancy. Typically, as soon as the mother gives birth, this resolves itself. People that had gestational diabetes are at higher risk of developing type 2 diabetes. Risk factors, it can be genetic, it could be metabolic, it could be emotional and physical stress can cause it. Obesity. It could be a virus can destroy some of the beta cells in the pancreas. So it could be related to a virus, or it could be the immune system, an autoimmune disorder where the body basically destroys the cells in the pancreas. Symptoms of type 1. Type 1 symptoms and type 2 are very similar. Basically, they're very thirsty, polydipsia, frequent urination, polyuria, extremely hungry, polyphagia, a rapid loss of weight, they're irritable, they're weak, they're tired, and often have nausea and vomiting. Type 2, kind of the same, polydipsia, polyuria, polyphagia, weight loss, poor healing. Now, this is often a sign. A lot of times when people maybe come to the hospital or to the doctor's office and say, I've got this wound and it's just not healing. You know, I've had it for months and months and it's not getting any better. That's a big sign of being diabetic. So you would definitely want to check their blood sugar to see if they are diabetic. This is why diabetics are told to have a mirror and check the bottom of their feet, because they get numb. They have tingling and numbness, and a lot of times their feet, they don't feel anything, and they'll walk and they can step on something, not feel it at all, and now they have a wound on the bottom of their foot that's not going to heal. So this ultimately could end up leading to amputation. So that is very important for diabetics to watch their feet, and they should always wear shoes, should never walk around barefoot. Itching, drowsiness, increased fatigue. To diagnose, we typically would do a fasting glucose test. Then also there's the hemoglobin A1C. The fasting plasma glucose, that would be a first indication. Then they could do a glucose tolerance test, which takes longer. It's like a 3-hour test where they have to drink this very sweet mixed drink, and they have to have their blood taken like every hour for 3 hours to see how well their body is processing the glucose. Hemoglobin A1C, that is a blood test, and it looks at a 3-month average of what your blood sugar looks like. So typically you want it to be under 6. If you're at like 5.9, that's pre-diabetic. So you don't want it even that high, but that still gives you're not considered diabetic at that point. I've seen some people as high as 15, 16, And then they say, oh yeah, I check my sugar, I watch what I eat, and you're looking at their A1C of 16 and you're like, yeah, sure you are. That's uncontrolled diabetes. That's very uncontrolled. You need to really teach your patient. They have to understand. They have to understand how serious it is. A lot of people just, I'm diabetic, and they just, are very flippant about it. They need to understand that they need to watch their glucose. They need to monitor it. They need to be diligent about taking any medication, like they may have oral medications like metformin. Some people check their blood sugar quite often and have to do a sliding scale of administering insulin. Diet is the best way to treat diabetes. So you really need to educate your patient on their diet. You want to put the emphasis on what they can have rather than what they can't, because that turns into the forbidden fruit. Exercise. It's very important to exercise. Often they do have to take their insulin. The goal is to, you want to keep everything on a very level. You don't want a roller coaster. That's the worst thing in the world, just have spikes and then your blood sugar drops and then it peaks again. That's the worst thing. You want to try to keep everything on an even keel, very level. You need to keep, they need to understand the insulin carbohydrate ratio. People think, oh, I'm diabetic. I gotta watch what I can't eat sweet stuff. Whoa, I eat so much sweet stuff, I'm going to become diabetic. No. It's carbohydrates turn into glucose. So 1 unit of insulin will cover 15 grams of carbohydrates for most patients. I was in a nurse's office at a school. I think it was a middle school, and it was lunchtime, and all these kids were lining up at the door, and they were telling the nurse that was there how many grams of carbohydrates that they had for lunch. And the kids were figuring out, they had like this, their little chart, and they were figuring out what they ate, how many carbs was in it, and then they looked to see how much insulin they needed. And each kid had their like little kit up in this cabinet with their name on it, and they'd pull it out, and they had these little insulin pens where they could dial it to how much insulin they needed, and they would inject themselves. And it was just fascinating to me because I've worked mostly with adults, and a lot of adults don't monitor their blood sugar that well. I'm sure with kids it's been just a way of life for them, but adults need to be taught that this is what they need to do. Giving insulin, it is a subcutaneous injection. It goes into the fat, not the muscle. It's a sub-Q. Often you give the belly or the underside of the arm. It does need to be rotated. You give your injection the same spot all the time, you're going to build up scar tissue. That's going to be, hard, and it's going to be harder to give yourself injections, and it's also not going to absorb the insulin properly. Here, here's the different kinds of insulin. And yes, you need to be aware of these, and you need to understand these. These are NCLEX questions right here. So you've got your rapid acting like Humalog or Novolog. That's rapid. That you want to give within 10 to 15 minutes before mealtime. It kicks in quick. Then you have short acting, which is like your regular insulin. That is kicks in about 30 minutes. And it's, it doesn't last as long, but it, it starts slower than rapid, but it kicks in pretty quick. Then you have your intermediate, which is your NPH. NPH, it typically, your onset is 1 to 2 hours. A lot of people, they will give mixed with regular and NPH, and that kind of gives them the quick onset and then also the longer lasting. And then, of course, you have your long-lasting, like Lantus. Lantus is a real popular one. I always think of Lantus and long-acting both start with L, so that helps me remember. Lantus is a long-acting. It typically lasts, it says here 24 hours. It's usually, you take it every 12 hours. I have a diabetic cat that gets 1 unit of Lantus every morning at 7 a.m. and every evening at 7 p.m. And that just keeps his blood sugar on an even keel. Diabetic ketoacidosis. That is very high blood sugar. I've seen people 500, 600s. I've seen some people that their blood sugar is so high it doesn't even register. That's pretty scary. This is life-threatening. They can very easily go into a coma and die from this. The body will break down your protein and fat. That's basically, those are your ketones. That's when you check the urine. People see the ketones in their urine. They will also have like a fruity smell to their breath, and that's also, again, the ketones. So let's see what you would want to do. Again, you will see all the typical signs of polydipsia, polyuria. There's the fruity. They're also very dry. Their mucous membranes are dry. They have sunken eyeballs, which shows like dehydration. So one of the things that we have to do is we've got to hydrate them. We got to get them hydrated. Here's interventions. You want to get their fluid electrolyte imbalance corrected. A lot of times at this point they will need IV insulin. And again, we do things slow and steady. So long-term complications of diabetes, you think about sugar basically going through your bloodstream. It's going to be causing damage all into your vascular system. It's going to be causing nicks and cuts, and then that ends up healing and you have scar tissue, and now you're going to start having obstructed vessels because of the scar tissue from all those nicks and cuts. So that pretty much can cause issues everywhere. Cardiovascular, CVAs are not even on here, but strokes are very common. I was on a stroke floor, and 3/4 of our patients that had strokes were diabetic. Nephropathy, very often are very common for diabetics to have a lot of nephropathy. We have to give them like something like gabapentin to help with their nerve pain. The peripheral vascular disease, you can see, like, look at people's legs and you can see the darkened thick skin, and that's lack of circulation. Retinopathy, it affects the vessels of the eye. A lot of times people they can go blind from diabetes. Oh, nephropathy is your kidneys. I'm sorry, I'm just out of this. Neuropathy is your nerves. Nephropathy, your kidneys. That is your, I was thinking the bottom one was kidneys for some reason, but your kidneys are temperamental. Your kidneys are usually the first organ that's going to have issues with pretty much anything. So that's why a lot of diabetics, they've really got to watch their kidneys. They've, a lot of them end up on dialysis, or they may even need kidney transplant. Hypoglycemia, this is your low blood sugar. And this one could be caused by it could be tumors, it could be alcohol abuse, it could be from surgery. So they are going to have rapid heartbeat, they're going to be weak, they're going to be nervous, they're going to be hungry. Biggest thing is they're going to be cold and clammy. And that's kind of a saying, is cold and clammy, give some candy. Hot and dry, get hydrated. Hot and dry is your DKA. That's what you said, is their mucous membranes are all dry. So you want to get them hydrated. Cold and clammy, that's low blood sugar. That's why it says give candy. So you want to raise their blood sugar. Cold and clammy, give some candy. Hot and dry, get hydrated. That's the best way to remember the difference between how a patient would look between DKA and hypoglycemia. Sick day rules. This is big with diabetes, and I've seen this on many tests, and it just seems to be a very common question. When someone's sick and they're diabetic, you want to give them their insulin, even if they're not eating. And that seems almost like, why am I going to give them this? They're not eating. They're going to become hypoglycemic. Well, when they're sick, their blood sugar rises. It's from the stress, and so their blood sugar will increase even if they're not eating. You want to still test their blood glucose every 4 hours. You want to encourage the liquids and rest. Watch for signs of DKA. But the biggest thing is you continue to give them their insulin and monitor it closely. All right, well, that concludes endocrine system. So if you have any questions, just reach out to me. Thank you.